السلام عليكم.
Waalaikumsalam warahmatullahi wabarakatuh.
Waalaikumsalam, Doktor.
Salam, Doktor.
How are you?
Alhamdulillah, fine.
Alhamdulillah.
Fine, Doktor.
All attendants already arrived.
There's a few more.
Okay. So today we are going to present a nice seminar. I got the slides from you. You did a good job. But now I am going to concentrate about the clinical sense of the knowledge. Okay. How to transfer knowledge to practice is a very important. Please make it in your mind. Let us start by Al-Kitab, and after that we'll start by the first presentation and simple comment, clinical comment or questions. After that we are going to for the second and the third. Okay, so let us read Al-Fatiha. بسم الله الرحمن الرحيم. الحمد لله الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم. Okay, Ayman.
Yes, Doctor.
We can start now.
Okay. So, Assalamualaikum warahmatullahi wabarakatuh. My name is Aiman, and me and my colleague Asfa and Shazwani will present the topics for tonight. So, I'll start with the first one. I will present about child with seizure and neonatal seizure. First, start with child with seizure. Okay, can you see the slide?
Yes.
Okay. So I'll begin. These are the outline. I'll talk about the terminology and then how is it classified, some causes, how to approach it in clinical sense, and then I will proceed to neonatal seizure. First, seizure. It is a clinical event in which there is a sudden disturbance of neurological function, either by abnormal or excessive neuronal discharge. And then there is focal seizure and generalized seizure. Focal seizure is the definition taken from Nelson. It is first clinical and electroencephalogy EEG change suggests initial activity in our system, which limited to one part of cerebral hemisphere, and then generalized, which involve both hemisphere. The next one is epilepsy. Clinically, it is defined by 2 or more unprovoked seizure occur in a time frame of longer than 24 hours. And then epileptic syndrome, a disorder that manifests one or more specific seizure type and has a specific age of onset and a specific prognosis. Last but not least, is status epilepticus is an emergency. It is defined by ongoing seizure activity or repetitive seizure without return of consciousness for greater than 30 minutes. So these are classification which are used in pediatric protocol made by International League Against Epilepsy 2017. First, they are divided into focal onset, generalized onset, unknown onset, and unclassified. Also, there's a special one for focal to bilateral tonic-clonic seizure. It is a quite, according to ILAE, it is quite common and special in its own way, because focal to bilateral means that it starts focally and then it progresses to bilateral, to other parts. It uses the term bilateral to differentiate it from generalized, which starts, which involve the whole hemisphere when it begins. So later I will share the PDF file, which is a guideline by ILAE, which will define all of these terms mentioned here in the types. So there are some causes of seizure. They can be perinatal, infection, metabolic condition, poisoning, neurocutaneous syndromes, systemic disorders, and other disorders. So for perinatal condition, can be structural abnormalities like malformation of cortical development or any intrauterine infection such as chorioamnionitis or GBS infection, and then hypoxic ischemic encephalopathy, trauma during birth, and hemorrhage infections, the encephalitis, meningitis, or TB, and then parasitic infection, and various metabolic conditions like hypoglycemia. Notice that there are some causes here. There's asterisk. There's a star here, which means that there are common causes. You see here. So child abuse, accidental trauma, and for neurocutaneous syndrome, systemic disorders, poisoning, which are quite rare. Then how we approach seizure. It's normally how we approach a case, which is first by taking history, and then we proceed to physical examination, proceed to investigation, and remain distribution. First, history taking. As you know, seizure, there are pre-ictal, ictal, and post-ictal state. First, we ask about the pre-ictal state. Initially, is the child well? If there is, ask also if there is any symptoms of infection, such as URTI, UTI, AGE, meningitis, which may precede or become the cause of the seizure, or if there is any warning signs which can help us to diagnose a specific case cause. We can point it. Then such as fever, neck stiffness, photophobia in meningitis, or encephalitis, and then diarrhea, vomiting, which can lead to dehydration, which can provoke seizure. Also, ask what was the child doing before the seizure, in which we can know if the triggers that causes the seizure to develop. Ask if there is any external stimuli. Is the child sensitive to light? Is the child listening to music at the time, reading? If there is any other stimulation like somatosensory or proprioceptive stimuli. Also ask for intrinsic stimuli such as movement. What is the child doing at the time? What was the child emotion during that time? What were they thinking? Did they express anything to you before the onset of the seizure? Also ask for any precipitating factors such as sleep deprivation, stress, or menstrual cycle. Also ask for any aura. Aura is a sensory experience reported by the patient. It must be reported by the patient, and usually it is not observable by people around them. So it includes any visual things, anything that they see, somatosensory, olfactory, auditory, vestibular, experiential. Experiential is a deja vu, according to Nelson. Then during the seizure, during the period, notice, ask anyone that sees the patient, how long does the episode occurs, and how many times does it occur, and does it occur before? Has it ever occurred before? And ask for the body movement. How does the patient move? How does the body move? And it's better to ask if there is any video recording of the episode. So yeah, if there is any video recording, and notice if there is any, ask the observer if there is any bluish discoloration of the face, any incontinence, any deviation of the eyes, eye rolling of saliva, clenching of teeth, and tongue biting. Post-ictal, ask if there is any loss of consciousness. How did they feel after the episode, and how long they return to the baseline, which we can pinpoint or know specific diagnosis such as absence seizure, which will return immediately to baseline, as if there is any drowsiness, feeling of confusion, or tiredness. So these are other histories that we can ask: past medical history, and history of head trauma, history of infection of the brain or spinal cord, history of any febrile or febrile seizure before. Has it ever happened? in this patient, and then history of depression, anxiety, or panic attack. Usually in this, I think hypoventilation can predispose to certain type of seizure, any sleep disorders, or any underlying medical conditions such as DM, hypertension, renal disease, and etc. Then for drug history, ask for any drug use such as antidepressant, antihistamine, or anticholinergic drug, or any steroid use. As also the parents or the mother, or if the patient, if they know about it, birth history, and antenatally, perinatally, and postnatal. Also, we need to know their developmental history, if there is any developmental delay or any cognitive problems, or maybe they have underlying problems such as cerebral palsy or autism, mental retardation. Then family history of seizure. Ask about if has seizure ever occur in the family and any of the family members, and if they have history of seizure, ask what was the diagnosis, if they know about it. When was it diagnosed? How was it diagnosed? And what was the management? And what is the prognosis of the family members that was diagnosed with seizure? Then social history, if there is any social history of abuse. So, and then that was all for the history. Then we proceed to physical examination. So for general examination, look if the patient is conscious and alert, look at respiratory distress. If the patient is in pain, because during the seizure anything can happen, maybe the patient injured or anything, or or maybe the pain is due to underlying cause. Look also for dysmorphism in the patient, because again, when we want to look for the cause of the seizure, maybe the child has any syndrome that we don't know. We also want to rule out all these types of syndrome, and look for if the child is well or toxic looking, which can rule out infection, and keep a review time and sign of a trauma. And important thing during physical examination, we need to check for vital signs, check for the blood pressure, temperature, pulse rate, respiratory, and SpO2. Then measure the anthropometric measurement of the patient, weight, height, head circumference. So, and then examine the skin. Don't forget to examine the skin in case of neurological, in the case of seizure. Look for any hypopigmentation, which can happen in tuberous sclerosis, any cafe outlet spot, neurofibromatosis. And for neurofibromatosis, you must also know the criteria, how many spots need to have, and some of the criteria. Also look for spider nevi. We can have ataxia, telangiectasia, port wine stain in stage Weber syndrome, hemangioma, and von Hippel-Lindau. Or maybe look for also for bruises in which the child may be abused by their caretaker or anyone. So these are common example. Port wine stain in stage Weber syndrome at the top left photo, then top right, some and for abuse bruises, as you can see. And then for any dilated vessels or any spider nevi, also cafe outlet spot, neurofibromatosis. So these for findings in tuberous sclerosis patient. They may have Ashleigh macule, Sjogren patch, or adenoma sebecum. So don't forget to do also a neurological examination. Look for chronic or Brunelleschi sign, any other sign of meningeal inflammation. However, these signs can be positive in units regardless, even though the patient has no meningitis. Also examine the ear, which can also be a source of infection. Don't forget also to check, to examine the eye, look for ptosis, squint, nystagmus, any dysmorphism, hypertelorism or anything. And then check for the iris for leech nodule, extraocular movement, any dilated pupils. Check for the lens, look at the cataract, look for cataract, then look for papilloedema, optic atrophy, or hemorrhage. For investigation, these are according to pediatric protocol. The first one is for if the child is presented with first seizure. So we do routine full blood count, profile, calcium, magnesium, and blood sugar. If the child is unwell and presented with vomiting, diarrhea, etc., and also if the child is not alert, lethargic, or failure to return to baseline alert. And then lumbar puncture is indicated if we suspect the child has brain infection. Don't forget also if the child has a history of drug exposure, any other medication that the child take prior to this. Screen for do toxicology screening, and proceed to EEG for all first febrile of unprovoked seizure patient presented to us. It can help us to classify seizure type, epilepsy syndrome, and predict recurrence of the seizure. And neuroimaging is also indicated in some cases. And according to this protocol, MRI is preferred. So it is indicated if there is any persisting postictal focal deficit, which is thought paralysis, or if the child itself does not return to baseline within several hours after the seizure. So this is for child presented with first seizure. And then the next one is epilepsy cases. Again, remember the definition of epilepsy. So when child presented with epilepsy, do full blood count, do full biochemical investigation like electrolyte, calcium, magnesium, glucose, liver function, renal function. And if the child has epilepsy and developmental delay, metabolic and genetic studies is clinically indicated because you need to find out the cause and maybe can help with the management. And again, EEG can help us in classifying the type, help us in predicts for future recurrence. The next one is if child with febrile seizure presented to us. I want to say that all of these investigation are according to individual case and not necessary to do everything. Okay. So for febrile seizure, lumbar puncture must be done if there is any symptom or signs suggesting of intracranial infection, or the child has persistent lethargy or not fully interactive with the parents or with you who are examining the child. And it also must be considered if child is less than 12 months old and has not received Haemophilus influenza B vaccination and pneumococcal immunization, and do it prior to antibiotic therapy. Also, don't forget biochemical like calcium electrolytes, but it is rarely necessarily in cases of febrile seizure, and EEG is not indicated in this case. Okay. So that's all for management. For investigation, so for management, there are emergency resuscitation. Then we treat, if we can classify or know the seizure, we treat them accordingly, and know when to refer to pediatric neurologists. And lastly, we need to educate or advise parents or teacher how to deal with a case of seizure whenever they encounter a child. So for emergency resuscitation, this is mentioned by Dr. Mossad previously. Maintain the airway, breathing, circulation, and then don't forget to do dextrose test. Also, the next one is disclosure. Expose the child and check for the skin because causes of seizure can be neurocutaneous disorder. And the last D is look for any deficit, neurological deficit. So again, this is the emergency management, maintain airway, breathing, and circulation, and watch out for status epilepticus in which the seizure lasts for more than 30 minutes. So if you observe the child has status epilepticus, so these are the management according to pediatric protocol. If the child has seizure more than 5 minutes, depending on the epilepticus, give parental diazepam or buccal midazolam. And when arrive at hospital, proceed with get IV access and give IV diazepam. If they continue, IV phenytoin, and if If the status epilepticus is refractory, consult to pediatrician, consult to a specialist, and consider to give one of these medications: midazolam, phenobarbital, DBT, Recitam, and sodium valproate. If it is more than 60 minutes, it is established that the child has refractory status epilepticus and discuss with specialists about the further management they can do. Don't forget also to maintain adequate ventilation, perfusion, check for blood sugar, and monitor for side effects of the medication given to the patient. Monitor BP, respiration, and all the other supportive measurement. Okay, that's for status epilepticus, which is emergency. Then these are the management according to seizure type and the type of medication that can be given. So for focal seizure, usually the first line medication is carbamazepine, and then proceed to valproate on carbazepine. Do know that for giving anti-epileptic drug, it is best to do it monotherapically and then optimize the dosage. Then for generalized seizure, most of the drug given is valproate. It includes for tonic, clonic only, then absent seizure, atonic seizure, and myoclonic. And do not for second line, most of them use lamotrigine, except for myoclonic seizure, where Levity, Recitam, and clonazepam are for second line. So if the child has epilepsy syndrome, then if we have established the diagnosis of the syndrome, so these are the drugs that should be given to the patient. For West syndrome, there is steroid or gabapentin, and then for Dravet syndrome, sodium valproate. Most of them are sodium valproate. Then this, however, we must be careful that because some epileptic drugs can aggravate certain type of seizure, such as phenobarbital, can worsen absent seizure, clonazepam, causes tonic-clonic, Lennox-Gastaut syndrome, and all others. Okay. And because we are giving these drugs to the patient, we must be careful and don't forget to check for side effects, especially for drug that has serious side effects such as Stevens-Johnson syndrome, hepatic toxicity, pancreatitis, encephalopathy, and peripheral visual field constriction. But don't just focus on serious side effects. So we need to look for common side effects also. And then lastly, don't forget to refer the patient. So these are the indications. So immediately refer the patient if there is any behavior or developmental regression, or if there is any infantile spasm. So that is for immediate referral. So later, after we manage the patient, after we follow up, refer the patient if the child has poor seizure control despite monotherapy with 2 different anti-epileptic medication. Means we have used the drug, we have optimized the dosage, whatever, and then the seizure still occur, and then we change drug, but then it still occur, then refer it. Then also, if there is any difficulty in controlling the epilepsy in the first 2 years of life, and if we found any structural lesion on neuroimaging. So these are first aid measures that we can educate the parents or teachers if the child under their care is experiencing seizure. First, tell them to do not panic and calm and note the time, the onset of the seizure, and then loose the child's clothing, especially around the neck, to avoid any asphyxia or any constriction of movement. Place the child in left lateral position, wipe any vomiters or secretion from the mouth, and do not insert any object to the mouth even though the teeth are clenched, and do not give any fluids or drugs orally. And stay near the child and care for them until the seizure is over, and comfort them while they are recovering. And it is best if these caretakers can record this child having seizure, because it can help us in determining the type of the seizure. So that's all about child with seizure. Any question? Or should I proceed to neonatal seizure immediately, Doctor? Doctor?
Okay, you can finish, Ayman.
Okay. So proceed with neonatal seizure. For introduction, in neonatal, seizure is the most common manifestation of neurological dysfunction in newborn. It is a repetitive rhythmic movement of the limbs that persists despite restraining the child, and often accompanied by a movement in change in respiration. So there are several factors that can predispose to neonatal seizure, such as birth factors. Example, hypoxia, ischemia, encephalopathy, and birth trauma. Also, if there is any developmental factor such as excitatory effect of GABA in immature brain. So besides seizure, there's also a condition that mimics seizure. So we need to differentiate this condition. Need to know how to differentiate this condition with the real seizure. So this condition is called paroxysmal non-epileptic. It includes jitterness, in which the movement is stimulus sensitive and it stops whenever the limb are flexed gently. And then next one, there's also benign neonatal sleep myoclonus, which occurs in sleep and aborts with arousal of the patient. And then there's startle disease, hyperreflexia, which is excessive startle, stimulus sensitive jerks, and generalized muscle rigidity. So these tables that differentiate the manifestation of the condition that mimics seizure and seizure, the actual seizure. So this is jitterness and seizure. First one, for seizure, they have abnormality of gaze or abnormal eye movement. However, seizure does not, the movement of seizure are not sensitive to stimulus. Like I explained before, jitterness or startle, the movement, the abnormal movement are sensitive to stimulus. So in seizure, the movement are not sensitive to stimulus. And then predominant movement for jitterness, there's tremor. However, for seizure, the movement are usually clonic or jerking. And then for jitterness, the abnormal movement can be stopped with passive flexion of the affected limb. Last but not least, there is autonomic changes in seizure, in which it does not occur in jitterness condition. So these are the types of neonatal seizure. There are subtle, clonic, tonic, and myoclonic. For subtle, because the motor movement, the limb movement are quite subtle and not as obvious with clonic, tonic, or myoclonic movement. So look for any ocular phenomena such as deviation of the eye, and then orbital lingual movement such as chewing, lip smacking, or cry grimacing. They also may have a mixed spell, which is common in term infants. And then the next one is clonic. Can be focal or multifocal. Then, so look for, according to the name, look for clonic movement or multifocal clonic movement. And then tonic, of course, as the term define, which is a sustained posturing of a limb, can be focal or generalized. And last but not least, myoclonic can be focal, multifocal, generalized, which can. So yeah. And these are the etiology of neonatal seizure. And different etiology has a different age of onset. So you can see here, most of these on the first one are less than 3. Some of them are less than 3 days. Some of them are more than 3 days. Can be variable, and then can be more than 7 days, less than 3 days, more than 5 days. So also note that some of these causes are common in preterm or term infant. So yeah, you can look at that later. And besides the normal investigation that we can do to find the causes of the seizure, there are also additional investigation whenever we can't pinpoint exactly what is the etiology of the seizure. So most of them includes tests that we can do to rule out metabolic conditions. You can see here so many tests that, yeah, so many tests. And notice that the test with hashtag here, these are tests that you need to discuss with neurologists or metabolic specialists before sending the sample or doing it on the children. Then for management, again, you need to get the history, do the physical examination. So get through history, and then do neurophysical assessment. For neurological seizure, EEG use is amplitude integrated EEG, which is EEG that is used to monitor the patient for a long term, can be hours or day, or can also use continuous video and EEG. So acutely administer IV anti-epileptic drugs to avoid the seizure. So these are the management. In ABC, do dextrose test. If hypoglycemic, give IV dextrose 10% and consider all this investigation to rule out the causes. And then if the seizure is ongoing, give IV phenobarbital. Still ongoing, give again phenobarbital, and then give it for 3 times. If it still occur after 3 administration of phenobarbital, give IV midazolam. And if the child is seizure free for 24 hours, start weaning child. So if we give midazolam and the seizure is still ongoing, we can give IV phenytoin, or we can consult to neurological consultant. So when we start the anti-epileptic drug in the patient, it must be considered to prolong the medication. If in these cases, prolong the maintenance period, we give is 6 to 12 weeks. If there is if there is a condition like high probability of seizure recurrence, such as stroke and hemorrhage. Also, if there is any abnormal neonatal neurological examination upon discharge of the patient, and abnormal EEG during discharge. So, yeah, I think that is all about neonatal seizure, and these are the prognosis. So, different causes, different disorder have different prognosis, as you can see here. So, that is all from me.
Okay. Thank you, Ayman. Hello?
Yes.
Can you hear me?
Yeah.
Thank you for nice presentation. Really, it is very good now. The most important lesson I need you to consider: every patient coming to us is a big dilemma, is a lot of details. Any diagnosis, it is not, epilepsy here is a rich diet about details, but really every patient come to you if you are not oriented about the main causes and the differential diagnosis and what you will consider, what is your emergency intervention, how can you handle the emergency situation, and how you can handle the family with chronic disease and like that, and even to be updated for new published material for that, and with time be engaged in that research it is very important. Okay, I would like to ask if there is any question about Ayman presentation. Alaikum salam.
I have a question regarding one of the causes of neonatal seizures would be the tortuous infection. And then may I ask, when it is in the PBS protocol mentioned that it's part of the workup in the cases of neonatal seizure, may I ask, is there any workup that we can do in order to do it like before the patient is born, like during the antenatal periods for us to detect the tortuous? So that we can like expect there will be a seizure in neonatal period. Thank you.
Yeah, I think if there is suspicious of the mother, the ONG is going to consider it, especially if they found some criteria for this torch disease for any of it, they will do. But most of the time, if we that cases will be investigated just after delivery, okay, to send this now torch screen and go ahead from that. The most important goal here is try to prevent. So the mother has risk factor like exposed to rubella, if she has previous cytomegalovirus, maybe if she got a lot of these things, it is better to consider preventive and other than treating. But it is easy to do the test for all this torch screen. If it is IgG, it means it is transmitted from the mother, but if it is IgM, it means that the baby already infected. Unfortunately, not all of them has treatment, but some only. Okay, but it may be your role to think for the future. As I told you before, it is 30 or 40 years ago when we are still student, we are hearing something and consider it as a dream. Now we can see it in the actual life. So please dream how you give benefit for the community, even for all mankind, and you will find your dreams, inshallah, soon applied. Okay.
Thank you, Prof.
Any other question?
Assalamualaikum, Prof. I would like to ask regarding one part of the management for at home management when the child get epilepsy. It is advised to put the child on the left lateral cubital left lateral position. Is there any significance why it must be left compared to right?
I think if he's facing you is the best. If he's back to if he's left side to you, it is better. If right side, suppose his back is to the wall and you are on this other side, it doesn't mean for me is there any side. But the issue here is if we put the patient on supine position, a lot of secretion may cause suffocation. Also, his tongue sometimes can be fall down and cause suffocation. So we are trying to put him to the side. In the Western country, they prefer to start from the left or drive from one way. But I think it is open to put him to right or left. Did you read anything about that, Ayman?
Sorry, just negatively about
it. In our concept, تيمنوا فإن في اليمين بركة. We feel that the right is بركة. If we can start by right, okay, no problem for that. The issue is don't put him on the supine, so he'll be suffocated, and don't put him on face, so he can during the convulsion he can traumatize his face.
Thank you.
Okay, so any other questions?
Prof,
Yes.
can I know why we ask about the steroid? During the past drug history, why we need to inquire about the steroid?
Can you decrease the volume slightly? Your volume bit high, yes.
During the past drug history, why do we need to inquire about the steroid usage?
Anyone can translate her message because your voice is not clear? Ayman or any colleague?
The question is from Anisolati. She
Yes.
asks, why in drug history we need to ask about previous steroid use?
Previous steroid specifically. Drug history must be very wide during epilepsy. Number one, if he is in medication, because as you know, if there is uncompliance, it can cause status epilepticus. Some drugs which can affect in high dose also, like toxicity or like that, must be considered. Consider steroid sometimes can increase the intracerebral pressure, pseudocerebri like that in some patients, okay, and must be given, but specifically for steroid, I need to research again. Okay. Why specific steroid, Ayman? Or it is just written in the protocol?
Pardon?
Why did you specify steroid between the drugs? Try.
Oh, I know, yeah, it can increase intracranial pressure. That's all.
Yes. Okay. Okay. Any other question? So before going to the second presenter, please remember that it is in the short time, inshallah, you will be in the emergency department or anywhere in clinic or in hospital or like that. If patient came to you, you must know what is emergency and how to deal with that. At the time, you need to work as a team. Okay, there will be one of the staff is inserting 2 lines, not one. It can be okay. If the patient is severe convulsion and cannot, we are going to consider rectal diazepam. And remember always that rectal diazepam is working like IV. So don't let trying to put line while the patient is convulsing and fail many times. You can just put rectal diazepam. The IV can be put in small syringe like insulin needle and given rectally or suppository. And I think the IV, they said it is comparable to the IV at the time. Subhanallah, this is maybe rahmah for that patient. You will assign one to go the investigation, including the dextrose, as we said, as a bedside. Another one can go through the history for the family, and you are concentrating on the lines of management. So you have the very nice pediatric protocol. I will start by positioning. I will start by evaluation ABCDE. Then I am going to start the Valium. If not response, I am considering the second line like that. So you must know how to deal with the emergency. This is number one, please. Number two, you must train yourself. The patient with chronic disease or severe disease, he needs specific communication with the family. So don't underestimate that, please. You must have a good bond with the family, because with time they are considering you as a one of their family. You are the one who is saving their child. You are the one who is always take care after him. So please don't underestimate that role. It is very, very important. Okay, this is the second point. as I told you before, observation is very important, as presented in the slide. Okay, especially if you suspect the patient has cutaneous, so you must ask yourself, beside neurological examination, go ahead for cutaneous, for infection, or like that. Eyes is very important in neurological examination, please. So don't underestimate that, especially if the patient has like nystagmus or he got squint. All can be a sign of problem in the nervous system. Okay. The last thing which Ayman spoke about is the CFM. What is CFM? Is cerebral function monitoring. This is just a simple EEG, either 3 lead or 5 lead. It is not that one which used by Dr. Azamin, 20 lead and a very big number, or 24 or like that. It is just simple, but it is very, very effective to tell us about the cerebral function state. Sometimes even some babies has atonic epilepsy. He doesn't have convulsion, but the brain is convulsing from inside. So it is very important. And this one, which I told you, with time you can evolve a lot of idea. You will find it, inshallah, in your practice. Okay, put in your mind, a convulsion can contain 100 differential diagnoses. Epilepsy itself has a lot of details to come to which type of your epilepsy. Okay, so don't accept in your life single diagnosis. You must put the differential diagnosis and what is support that and what against that. Okay. Thank you for excellent presentation. Let us go for the second presenter, please. I'm trying to use 2 computers to see your slides good because the mobile is very small.
Can you all see my slide?
Acute flaccid paralysis. Okay.
Yes.
I see it in my computer also. Okay, go ahead.
Okay. So in the slide presentation, right?
Yes, yes.
Okay.
Clear.
So my name is Muhammad Asfar. So I will present about acute flaccid paralysis. So we go to the definition of acute flaccid paralysis. So by word itself, so acute is a rapid progression of paralysis, and flaccid is a loss of muscle tone, and paralysis is referred to weakness, loss of voluntary movement. So based on CPG, acute flaccid paralysis is occurs when there is a rapid evolution of motor weakness, which is less than 4 days, with lost tone in paralyzed limbs. This includes weakness due to trauma and spastic paralysis. Okay, this is the definition based on CPG. So when we talk about acute flaccid paralysis, so it is a medical emergency and less frequently weakness of respiration and swallowing, and progressing to maximum severity within days to weeks, and can result in death and disability. So this is a very important topic. Okay, so in regard of acute flaccid paralysis, so there's a several differential diagnosis of AFP. So I refer it to as a AFP. So it's based on the location of the the lesion itself. So if it is located within the spinal cord itself, so we can consider as acute transverse myelitis. So if it's is referred if the lesion is on the anterior horn cell, so it is maybe caused by the poliomyelitis enterovirus, and if it is the lesion on the peripheral side itself, so we might consider Guillain-Barré syndrome. So that was several diseases that I would like to focus on. So if it is on the acute anterior horn, so you will consider acute anterior poliomyelitis. So the causes is a poliovirus, and for the spinal cord itself, acute myelopathy. So we can consider acute transverse myelitis, space occupying lesion, and also peripheral if it is on the lesion on the peripheral nerve. So it can caused by the Guillain-Barré syndromes, post-rabies vaccine neuropathy, and all of these reasons. If it happen on the neuromuscular junction, so we can consider myasthenia gravis, toxins or paralysis, tick paralysis. For muscle itself, so we can consider hypokalemia, hypophosphatemia, all of the electrolyte imbalance, inflammatory myopathy, and also the others can be considered stroke and encephalitis. Okay, so when we talk about acute flaccid paralysis, in Malaysia, this is a very important topic and very important disease. Why? Because we must consider poliovirus as one of the causes of acute flaccid paralysis. That's why when this case happen in your, for example, you work in the public health, so this is an important, or you work in a clinic kesihatan in GP. So if there's a case of acute flaccid paralysis, you need to notify the public health because in globally, we want to eradicate the poliovirus itself. That is one of the initiative. Same in Malaysia. Okay. So this is a case definition of acute flaccid paralysis. So any child aged less than 15 years develop an acute onset of flaccid paralysis should have poliovirus infection ruled out. So that's why we have the protocol of AFP surveillance in Malaysia. This is based on CPG. So for case detection and diagnosis, the case reporting is within 24 hours, timing of stool specimen within 2 weeks of onset of paralysis, collection of specimens, transport of stool as soon and as able, and follow-up patient within 60 days of paralysis. You can read it by yourself in the CPG. Okay, so this is based on the studies, 5-year surveillance of acute flaccid paralysis in Malaysia from 1997 to 2001. So it was founded that the causes of the AFP itself is Guillain-Barré syndrome, central nervous system infection, transverse myelitis, non-polio enterovirus infection, and hypokalemic paralysis. Okay. So this is the algorithm in order to know the cause of acute flaccid paralysis. Acute flaccid paralysis. So for example, if there's a new onset, for example, the patient come with the onset of difficulty in walking. So the first thing that we need to know is from the history itself. So we might question this question to the patient itself or to the parents. So we need to check the sphincters whether it is preserved or not. So if it is preserved, and also we ask about sensory loss, non-sensory loss, and if the reflexes is reduced or normal, so the causes might be due to the muscle itself. So if the sphincters is preserved, however, it have the glove and stocking sensory loss and also absent reflexes, we might consider peripheral nerve as one of the causes of AFP. But if it is the sphincter is preserved and the sensory loss is which is located dermatomally, like we know the site itself. So it might be cause of the spinal cord itself because spinal cord has a exact level of the lesion itself. So that's why we know the dermatomal lesion of the AFP. Okay, so that's why we have a several differential diagnosis for muscle, peripheral lesion, and also spinal cord lesion, and also the investigation also different. Okay. Okay, so when the clinical approach to child with acute flaccid paralysis, so on HOPI, of course, the patient will come up with paralysis. So we need to know the development of the paralysis itself. It is hours to days, symmetrical or asymmetrical. This is important because I will explain further in the specific disease of the AFP itself and the progression of the paralysis. Is it ascending or descending? So for example, in transverse myelitis. So if it is bilateral and symmetrical, so we might consider transverse myelitis. But if the progression of paralysis is ascending, so we might consider Guillain-Barré syndrome, right? Okay, so and then next we want to ask about fever, the onset of fever, because we want to rule out if this is an infection itself. For transverse myelitis, patient come with fever. Poliomyelitis also patient come with fever. And then if patient come with loss of reduced sensation, so loss of sensation can be due to compressive myelopathy, transverse myelitis. Reduced sensation also can be due to Guillain-Barré syndrome. And also for neck stiffness, in polio, GBS, and transverse myelitis can have neck stiffness. And also we must also ask about bladder involvement, because if patient with compressive myelopathy and transverse myelitis might come with bladder involvement. For autonomic system, cranial nerve involvement, so we might also be cranial involvement if it is involving the bulbar involvement itself. For example, in poliomyelitis, can come with cranial nerve involvement. Ptosis, we might consider myasthenia gravis and botulism. And facial weakness, we consider GBS, myasthenia gravis and botulism. And also painful spine movement, we might consider trauma itself, epidural abscess. And also respiratory insufficiency. In poliomyelitis and GBS, patient can come with shortness of breath, this is very emergency cases. Okay. So the history we must rule out trauma itself. So we ask about history of trauma to the neck or head. Okay, environmental exposure, if the patients involved with lead, arsenic, snake venom, dog bites, we might consider rabies. Okay, so preceding infectious prodromes like GBS and transverse myelitis, precipitating factors, for example, diarrhea. So we might consider the electrolyte imbalance, okay, postprandial hypokalemic radial paralysis, and intramuscular injection, polio itself. And also we need to ask about history of immunization, whether the patient is taking immunization or not. Okay, okay, so physical examination. So basically, for this case, the most important one is a neurological examination, the comprehensive neurological examination, including assessment of muscle strength, tone, deep tender reflex, cranial function, and sensation. So we assess all of this, assess for fatigability, autonomic features, bowel and bladder dysfunction, sphincter tone. So that's why we need to do the rectal examination, skin, ticks, fangs mark, because we want to consider like the toxin involvement. Fasciculation is often cited as a sign of anterior horn cell damage. Tone is reduced in transverse myelitis, GBS, and poliomyelitis. Distribution and degree of weakness, looking especially for extraocular muscle, facial muscle, and bulbar involvement. Reflexes are the deep tender reflex loss, depressed or preserved or breeze, sensory impairment, spinal tenderness, or straight latex for radiculopathy. Okay. So investigation, the history, physical examination, and investigation, this is just a general clinical approach for acute flaccid paralysis. After this, I will explain by the disease itself. So investigation, we might consider an electrophysiological study. So important for determining the diagnosis and prognosis of the lower motor neuron disease. So we can do the nerve conduction velocity to measure how fast an electrical impulse moves through nerve, to differentiate between demyelinating and axonal neuropathies. And we can also do the electromyography, distinguish denervation from myopathic involvement. And we can do cerebrospinal fluid assessment analysis to suspect for any CNN infection. MRI of the spine, this is important in the spinal cord lesion, especially the transverse myelitis, creatine kinase, because we consider the lesion of the muscle itself, so we need to do the creatine kinase, and also the serum electrolytes. Okay. Basically, it is based on your differential diagnosis itself. When patient comes with some sort of presentation paralysis, so we need to list out what is the diagnosis. So based on the diagnosis, we can do the exact investigation to rule out the disease. Okay, so we go to the first disease that I would like to focus on, which is the acute transverse myelitis. So based on the literal definition itself, so transverse is the extending across something, and also myelitis is the inflammation of spinal cord. So in acute transverse myelitis, it is an inflammatory process that is localized over several segments of the cord and functionally transect the cords. Okay. Usual level of myelitis is usually a thoracic level, so involvement of leg, bowel, and bladder. We must always be considered in weakness without bulbar involvement. Also, spinal cord dysfunction with development of neurologic sign and symptom, motor, sensory, and autonomic dysfunction. Okay, so the causes of transverse myelitis, so 40% of it is idiopathic. Okay, so it usually occurs as a post-infectious complications and presumably results from an autoimmune process. So 30 to 60% of the idiopathic transverse myelitis cases is an antecedent respiratory, GI, or systemic illness. These are considered idiopathic because the causative virus is seldom proven. Okay, so post-infectious likely predominate in children. Or the other causes of transverse myelitis is maybe due to the direct infection to the spinal cord itself, and also any systemic response to the infection. For example, if the patient infected by enterovirus, varicella zoster virus, herpes virus, and Listeria monocytogenes. And also if transverse also might be caused due to other conditions such as the autoimmune one, the SLE, and also multiple sclerosis. Okay. Okay. So the clinical features for transverse myelitis, so it is acute transverse myelitis. Okay. So time to maximum disability is more than 4 hours and fewer than 21 days, peaking within 2 days. So if acute is over minutes or hours, for subacute is over days or weeks. So for motor symptoms, so it is rapidly progressing symmetrically paraparesis with initial flaccidity followed by spasticity. Okay. So sensory, pain and paresthesia, back pain and sensory level. For autonomic, bladder and bowel retention in early phase, incontinence in the late phase. Okay. Okay, so this is the diagnostic criteria for transverse myelitis. First one is bilateral, but it is not necessarily symmetrical. Sensory motor or autonomic spinal cord is fine because this is the lesion is on the spinal cord itself. So spinal cord have a specific level that we already learned. So that's why the symptoms will in the physical examination we might the finding will show like a clearly defined sensory level. Okay, so because that's why we know the exact involvement of the spinal cord, and then the progression to nadir of clinical deficit between 4 hours to 21 days after the symptoms after symptoms onset. And also demonstration of the spinal cord inflammation, CSF phagocytosis or elevated IgG index, or MRI revealing a gadolinium enhancing cord lesion. And also exclusion of compressive post-radiation, neoplasty and vascular causes. So this is the criteria to diagnose transverse myelitis. Okay. So this is the fourth criteria. So diagnostic evidence, the picture. So for the MRI spine, shows a gadolinium enhancing cord lesion suggested inflammation. So we can see this is the normal one, and this is the gadolinium enhancing cord lesion. So we can see the swelling of the spinal cord itself. Okay. And also we can do MRI brain to rule out for any brain lesion, for example multiple sclerosis, and also we can do CSF analysis because this is the fourth criteria. We want to do if there's any pleocytosis or CSF protein. And also we can do antibodies such as anti-AQP4, anti-MOG and ANA, because one of the causes of the transverse myelitis is autoimmune. So we want to see whether there's the antibody is there or not. Okay. So the treatment for transverse myelitis is a definitive immunotherapy. So we consider IV methylprednisolone 30 mg per kilogram per day. So maximum 1 gram. So given daily or in divided dose for 3 to 5 days, and followed by oral prednisolone 1 to 2 mg per kilogram per day, maximum 60 mg daily to complete for 2 weeks. We give longer course of oral prednisolone for transverse with residual deficit. So high dose, which is 1 to 2 mg per kilogram per day for 3 to 4 weeks, then taper the dose gradually over another 2 to 4 weeks. So if there's no response, so we can consider IV immunoglobulin 2 gram per kilogram over 2 to 5 days, and or referral to pediatric neurologist for a better consultation. Okay. Okay, so prognosis in transverse myelitis, most patients with idiopathic transverse myelitis have at least a partial recovery, which usually begins within 1 to 3 months and continues with exercise and rehabilitation therapy. So recovery can proceed over years, and 40% may have persistent, and a very rapid onset with complete paraplegia and spinal shock has been associated with poorer outcome. Okay. That's for transverse myelitis. Now we go to the Guillain-Barré syndrome. So Guillain-Barré syndrome is a rapidly progressive acute demyelinating disorder. So it affecting motor axons that results in ascending weakness. Okay, this is like what I say is a pathognomonic ascending weakness, also sensory and sometimes autonomic nerves. So may lead to death from failure or respiratory muscle over a period only several days, and it is considered to be post-infection. So immune-mediated disease targeting a peripheral nerves, because we know Guillain-Barré syndrome also always in our minds, Guillain-Barré syndrome is a post-infectious by the organism Campylobacter jejuni, right? Okay, so the preceding effect absolutely 10 days, so patient might come with the symptoms of the infections of the Campylobacter jejuni. For example, GI infection, so patient come with diarrhea 10 days before the symptoms of the Guillain-Barré syndrome develop itself. So that's an important history. Okay, so the pathogenesis of the Guillain-Barré syndrome, Guillain-Barré syndrome. So for example, infection with Campylobacter jejuni, so it will trigger immune response and produce antibody against the microorganism liposaccharide. So when there's a immune response and the antibody produced towards the microorganism liposaccharide, so these antibodies sharing the antigen of the microorganism liposaccharide sharing homologous like it's the same. Okay, so it is called as a molecular mimicry. So when this happens, That's why antibodies cross-react with a specific neuron along myelin. So it will cause demyelination disorder result in the defect of the electrical nerve impulse. So that's why instead of the antibodies attacks, yeah, it will attack the organism itself, but it also attacks the myelin itself. So that's why, yeah, it's a it will demyelinate it. Okay, so that's why it will cause delay and impairs impulse transmission along the dorsal and anterior nerve roots. Okay, this is the pathogenesis. Okay, so clinical features. Okay, initial symptoms, basically patient will come with fine paresthesia in toes and fingertips. So it will progress lower extremities weakness that may ascend over hours to days, involving the arms and cranial nerve. In severe case, the muscle involved respiration is also involved. So this is very severe. For autonomic system, very commonly see. So this is for vital signs. So we must see the blood pressure itself. So there's a wide fluctuation in blood pressure, postural hypotension, cardiac dysarrhythmia, fatal antidepressant need voluntary support, and also motor system, rapidly evolving flaccid motor paralysis with or without sensory disturbance, ascending and symmetrical type paralysis. Weakness involves over hours to days. So the legs will be more involved compared to arm. So basically clinical features, you must remember the pathognomy itself. It's an ascending disease. Okay, from lower to upper. Okay. So for sensitive system, proprioception is more affected than pain, temperature, sensation. So for bladder, only seen in severe case. If bladder dysfunction is prominent, comes early in the course, think of other pathologies like spinal cord disease. Okay, for pain, usually it is deep aching pain in weakened muscle. For deep tendon reflex, the reflexes attenuated, disappearing in a few days of onsets. For cranial nerve, if it is involved, so it will cause facial diaparesis, so lower cranial nerve, bulbar weakness, ophthalmoplegia, and also pupillary paralysis. Okay, to diagnose the Guillain-Barré syndrome, so this is the criteria. A clinical diagnosis can be made by history of progressive ascending weakness, okay, ascending weakness, less than 4 weeks with areflexia, okay. So the second one is elevated cell protein level and normal cell count. So showing protein cellular dissociation. So we must do nerve conduction study because it is a confirmatory reveal slow nerve conduction. Okay. So other investigation we must consider, for example, the pulmonary function test, because patient might it might involve the respiratory system, and also serum autoantibodies. So you know the pathophysiology, right? So it because of antibody. So this is the antibodies. Renal profile to check for the syndrome of SIADH occur in some of patient. Liver function tests are elevated in 1/3 of the patients, and also inflammatory marker, because ESI may be elevated in a systemic inflammatory condition. Okay. So management. There are several management. So the first one is supportive care. So we must do the vital monitoring, the blood pressures, the ECG itself. Okay. So and then mechanical ventilator support if it is involving the respiratory systems, and patients should be monitored closely to treat the problems that can affect paralyzed patient. Okay. And also we might give low molecular weight heparin and compressive stockings to reduce the risk of venous thrombosis. And also we can give immunoglobulin intravenously to reduce duration and severity of paralysis. So high dose of immunoglobulin can block the damaging antibodies that contribute to DPS. Okay, so they fight back the antibodies. Okay, so another one is we can do is plasmapheresis, which the antibodies that involved in damaging the myelin itself will be filtered out bloodstream, thus reduce the severity and duration of the DPS episode. Okay, this is one option. Okay, and another management is physical therapy. So it will help the patient to perform routine of passive range of motion to keep the patient muscle flexibility. And once patient regain the muscle controls, assist them to have correct functional movement to regain strength, endurance, and gait equality. This to prevent them from getting joint contracture, back sores, and cardiopulmonary difficulties. So this is supportive therapy. And also occupational therapy, assist patient to use equipment such as wheelchairs, special cutlery, etc. correctly to improve activities of the delivery, and also speech and language therapy to help patient to regain speaking and swallowing ability, especially if patient was intubated and intubated for mechanical ventilation. Okay. Oh, kosong. Okay. So this is the case that the scale that's used for GBS. So Hughes functional scale for GBS. So 0 to 5. So this is important to know the severity of the GBS itself. Okay. Okay. The third case is poliomyelitis. Okay. So poliomyelitis. So this is the important disease that we must consider in acute flaccid paralysis. Okay. So this is a global initiative to eradicate poliovirus. So Malaysia also involved in this initiative, and we also must really involved in this initiative when we become a doctor. Okay, so it is a disease due to poliovirus infection, often characterized by acute onset of flaccid paralysis. Polio has been eradicated in Malaysia since year 2000, but and is mandatory notification to nearest district health officer within 24 hours by phone, followed by notification form. Even though it is eradicated, but the effort must be continued. So that's why in AFP, consider poliomyelitis. Okay. So criteria for diagnosing acute poliomyelitis. So it is a poliovirus, is isolated, either wild type or vaccine strain, or positive serology, fourfold or greater rise in antibodies, or epidemiological linkage to confirmed case. Okay. This is criteria. Okay, so presentation for poliomyelitis. The initial presentation, patient might come with fever, headache, vomiting, constipation, neck stiffness, leg pain. So, and then patient will come with very muscle weakness, may include respiratory failure within 1 to 2 days. Usually the presentation will, the proximal part will be more involved compared to distals, and legs will be more involved than arms weakness. Okay. So, a patient will come with reduced tone, mostly asymmetry. So if it is symmetry, we must consider what? Transverse myelitis, okay? Because usually it is bilateral and involves spinal cord. And reduced reflex, normal sensory. And if it is involved bulbar involvement, so patient might come with dysphagia and dysarthria extra. Okay. So for poliomyelitis, the investigation, so we do the cerebrospinal fluid analysis. So patient, it will show the pleocytosis, the polymorphone nucleus, then shift to lymphocytes, high CSF protein. And also the gold standard is we do the PCR from the CSF itself, okay, to what, there's a presence of the virus itself. And then virus isolation from the throat and stool, and also electrodiagnostic test. Normal sensory nerve study, reduced motor nerve study. Okay, because why it is a gold standard, because we need to see the criteria for diagnosing acute poliomyelitis itself. So isolated poliovirus, positive serologies. Okay, so that's why the investigation is based on the criteria itself. Okay, so the treatment for poliomyelitis is basically supportive. So we give pain relief, physical therapy, and also mechanical ventilation in respiratory failure. So that's why prevention is the most important part in eradicating the poliomyelitis. That's why when we become a doctor, so we need to educate the parents to always make sure that his child, son or daughter, to take the vaccine, and the vaccine is up to date. Okay. Okay. So this is the table to summarize up all the disease that can present with acute flaccid paralysis. So transverse myelitis, poliomyelitis, and Guillain-Barré syndrome. From the development of the paralysis, the investigation, CSF, how the blood dysfunction, the nerve conduction, and the diagnostic test. Okay, so this is a summary. Okay, thank you. So this is the reference that I use.
Okay. Thank you. As Doctor, as good as the other, mashallah. Now you send me old version of your lecture about half of the knowledge is not available for this presentation with me. Okay. but you did a good job. The first and the most important point is acid, not acid fast, but it is acute flaccid paralysis. Is a notifiable disease. Please make sure that you are making a notification. Even if you suspect it is not polio, you must make notification. Okay, it's obligatory. And the most important point is to get history from the family about vaccination, because we started to hear about some anti-vaccine persons. Okay, so it is very important to ask about the original vaccine, and even if the community is advising for extra dose like that, there must be compliant. Okay. The third and very important thing, when you got certain symptoms, you must think what is the top urgent and the most critical thing. I speak to you before about fever. If you got fever, before we must rule dengue, yes, and the other diseases like chikungunya, like myelidosis, like leptospirosis, because these diseases we hear it is around us. Now we must put like COVID test, because if you miss one case, it means it will go to the community and infect unlimited number of people. Okay, so it is very important. If you find something like that, acute flaccid paralysis, please. And as we see, differential diagnosis with the last table, the one before the reference Azhar.
This one?
Yes, how to differentiate. If you try to spend a few minutes to concentrate, you can get initial easy clinical differentiation. Okay, and also I remember before at 1980s, while we are seeing a patient like this, we put him in the hospital under close observation in high dependence unit and waiting for intubation. We just, every time we see him, we just make simple pulmonary test, which we try to tell him, I need you to count by one breath from 1 to 20. So we will get breath and 1, 2, 3, 4, 4 until 20. If he is coming to 20, we are free that the respiratory muscle is working nicely, because this patient can die from, if Guillain-Barré syndrome, from respiratory failure. So if I put him on mechanical ventilator, I will save him. Now we have formal spirometry, we can measure, but at least at the time, if you find him, he cannot go like before, count until 20, or he can count only to 10. You must take decision, please, because at night time he may deteriorate. Okay, so it is very important. Steroid now playing a very important role, like transverse myelitis and other immune modulating drugs. So not every infection means or every disease means antibiotic. Okay, please. You can find now transverse myelitis as its treatment is different. If you come to Guillain-Barré syndrome, it is symptomatic. We may consider IVIG certain limitation. It is not the antibiotic. We need to stop the idea of every patient must get antibiotic for anything. It is not good practice, and it will increase the resistance inside the community, which is very harmful. Okay, I think just notice one making a joke. He said fever is not indication for antibiotic deficiency. Fever is not indication for antibiotic deficiency, so you need to compensate for this antibiotic. Okay, fever has a lot of causes, and viral, maybe other diseases, maybe. It's your turn now. If you need to ask any questions, please.
I have a question. I'm not sure if I missed some points.
Does GBS reversible? Can the patient fully recover?
Why not? Can be if you passed already the area of death due to unsupported respiration. You know, many cases of COVID, even in developed countries, okay, cannot survive because there is no enough ventilator. Really, if you secure the respiratory, the patient will take time, but he can survive, yes. Usually he may need ventilation between 2 to 16 days, or it may be a different number of days. And after that, you can extubate and he will start again. His nervous system will work. Let's say I'm speaking about the, subhanAllah, I remember in 1985, we have one professor, he said at that time, research is not so high and facilities sometimes is not helping. He said, if I'm trying antibiotic and there is no response, I will support it by steroid. But don't do like that. I am the one who selected the case and know when to give this one. Now we are speaking about steroid can make benefit for many things. Okay, so please scan and don't put off. Now we are speaking for some malignancy in neonates, which abruptly the patient can survive and continue his life. So nothing must push the doctor to fade up. Okay, don't fade up for any case. I remember it is 200 years ago when they diagnosed TB, the diabetes mellitus. If they found someone who got the classical symptoms of diabetes mellitus, okay, they just offer to see the urine. If it is sugary, they picked that point. They tell him, be strong. It is a matter of 2 years, you will die. They are not thinking they can do for him either insulin or oral anti-diabetic, or even now pancreas, either artificial pancreas or actual pancreas. So a lot of things can be done. This is your rule, please. In the future, your rule is try to find the treatment for any disease, because the Prophet himself said like that. ما أنزل الله من داء إلا أنزل له دواء إلا الهرم. And if Allah send the disease, He also send the cure for him, if you know or don't know. علمه من علمه وجهله من جهله. إلا الهرم, there is some exclusion if one became so older and his organ failures like that. So please don't fade up. Yes, Gallenberry can survive, and even brain tumor, the survival for brain tumor is more than 80%. The acute ALL, the survival is more 90%. Yeah, before we are very pessimistic. Now we are very optimistic, inshallah, and we will increase our optimization. Okay.
Thank you, Professor.
Any other question? Or we can go ahead for the third presentation.
Prof, I have a question.
Okay.
Regarding transverse myelitis, my question would be that first and foremost, is it like a standalone diagnosis? Because, for example, in let's talk about neuromyelitis optica or multiple sclerosis, I thought that those diseases have transverse myelitis. So, is it like a standalone? Second one would be that in transverse myelitis, what would be the pattern? Is it ascending or descending in terms of the motor weakness? Thank you, Prof.
Okay, for the first point, no, it is not solved. But you are put it according to the clinical scenario in front of you for this table. Okay, it is very important to rule out, especially MS. All this will be guided by the history and the family history and the previous diseases, like you got recent infection or not. Okay. So no, even if you are treating a diagnosis and you make sure, you must ask yourself what can be the second or third diagnosis. I am not telling you you must come to the number 10 and the number 20 differential diagnosis. They can still can be. I think now we can go for floppy infant. I am afraid that there may be one needs the computer after the Zoom after our session. Floppy infant, please.
Okay, can you see my slide?
Yes. If you can make it presentation, it is better. Yes.
Okay.
Yes. I believe
so,
I hope everyone can switch off the microphone, please.
Okay. Okay, so I will be the last presenter for tonight's presentation. So my topic will be floppy infant. So can you see this posture of the infant? So this infant had a floppy posture. Okay, so these are my outline. So I will focus more on 4 disease or syndrome. So the first one is Prader-Willi syndrome. Second one is spinal muscular atrophy. The third one is myasthenia gravis, and the fourth one is congenital muscular dystrophy. Okay, so we move on to the definition of floppy. So floppy can be used to mean there will be decrease in muscle tone, which is we can say as hypotonia. The second one is decrease in muscle power, which is weakness. And the third one can be said as ligamentous laxity and increased range of joint mobility. But for definition of floppy infant itself is generalized hypotonia with or without weakness in infants. So how to approach? These are the approach to differential diagnosis in floppy infant. So at first we see the infant having hypotonia. So first we need to identify the neuroanatomical sites of the lesions or insult. So we need to determine whether it is from upper motor neuron lesions or lower motor neuron lesions. So if upper motor neuron lesions, it can be due to central causes. And if lower motor neuron lesions, it can be due to peripheral causes. Okay, so after we locate the neuroanatomical sites of the lesions, then we need to determine whether the infant the hypotonia is accompanied by weakness or not. So if there is no weakness accompanied, then we can call as floppy strong. But if there is a weakness, we can call as floppy weak. Okay, so these are the causes which I separated. So the central causes is from brain and spinal cord. For peripheral causes, it can come from the anterior horn cell, peripheral nerve, neuromuscular junction, and also muscle. Okay, so these are the signs that we can see when we see the hypotonic infant. So for the central causes, so the infant may have social and cognitive impairment, but otherwise there is not we not really can see there is a significant hypotonia, and the infant had normal of this deep tender reflex. However, as we compare to the peripheral causes, so we can see there is a significant signs whereby there is a hypotonia, hyporeflexia, and also there will be motor delay only with muscle atrophy. But they will have normal social and cognitive. Okay, so move on to the central causes. So it can be divided into brain and also spinal cord. So the brain can be due to brain tumor, trauma, infections, hypoxic and ischemic encephalopathy, and also some of the genetic abnormalities like Down syndrome and also Prader-Willi syndromes. So for the spinal cord, like as I mentioned, transverse myelitis, infection, trauma, etc. and also. Okay, for peripheral causes, so the cause. Okay, you can see Okay, so from the anterior horn cell, so when there is a problem with anterior horn cell, so the example of disease which is spinal muscle atrophy can happen, and also poliomyelitis. Okay, and the other one, and the rest. Okay, can read later. Okay, so okay, I will explain for the first syndrome, which is a Prader-Willi syndrome. Okay, so Prader-Willi syndrome. Okay, Prader-Willi syndrome is a complex genetic condition that affects many parts of the body. So it will affect the chromosome. It will affect the chromosome, which there will be deletions of the maternal copy, which involve 15q11, q13, and then the manifestations of the Prader-Willi syndromes is like hypothalamic dysfunction. So these are the features of the Prader-Willi syndrome. So the infant may have severe hypotonia, which is the hallmark of neonatal hypotonia. So the infant may have breathing difficulty, and also when the infant going older and older, so which the age reach 1 year old to 6 years old, so they will have unregulated appetite, so which is hyperphagia. So when there is hyperphagia, they eat a lot and they gain weight a lot, and so this will expose them to childhood obesity. So when there is a childhood obesity, so there will be many complications from the obesity itself, like um, uh, OSA, obstructive sleep apnea, type 2 diabetes mellitus, they are prone to that disease. So apart from that, there will be short stature due to growth hormone deficiency, and also this syndrome may affect the sleep-wake cycle, so they will have a sleep disturbance. And also we can see there is a hypogonadism, and also the Prader-Willi syndrome also associated with mild intellectual disability, and it is common. It is common to see in any childhood with Prader-Willi syndrome. So and also the best part is not the best part. The patient with Prader-Willi syndrome may have behavioral problems, so they will be so stubborn, and they will go into tantrum until this will affect the education in their school. Okay, so this picture shows some features of Prader-Willi syndrome. So you can see first at the face, so there will be narrow bifrontal diameter, almond-shaped palpebral fissures, and a thin triangular upper lip. So, and the patient looks obese, right? Okay. So these are other features of the Prader-Willi syndrome that we can see. So, okay. Okay. So to diagnose the Prader-Willi syndrome, we need to do genetic testing. So the genetic testing will involve the microarray analysis, and also we can do fluorescent in situ hybridization, which called as FISH, to confirm the prenatal diagnosis. Okay. So the next one is spinal muscular atrophy. So the spinal muscular atrophy is the autosomal recessive, which involve the degenerations of anterior horn cell. So when there is the degenerations of anterior horn cell, there will be progressive weakness and muscle wasting. And so in this disease, there will be biallelic deletions or mutation, which involve the survival motor neuron 1, SMN1 genes on chromosome 5q13. Okay. And then this will result in deficiency of the SM1 protein. So the presentations of the infants or the child, they will have severe hypotonia, generalized weakness, areflexia, tongue fasciculations, and also signs of lower motor neuron disease. Okay, so for spinal muscular atrophy, it has 4 types, with types 0, 1, 2, 3, and 4, and the types is classified based on the the age of onset, and also the clinical course. Okay, so you can see there is a 4 types of the SMA, spinal muscular atrophy. So there will be different features on each type. And then, so for the normally for the type 0 and 1 are the most common and severe types. because especially in type 1 SMA type 1, so there will be the infant will die due to respiratory failure. Okay, so the diagnosis can be made by genetic testing. So we can use other enzyme to diagnose any other investigation to diagnose, but what currently and widely used, which is the genetic testing. So we need to see the deletion or mutation of SMN1. So the creatinine CK and also EMG also can be used, but and also the last one is muscle biopsy, but these are seldom used in to diagnose spinal muscular atrophy. Okay, regarding the management of the spinal muscular atrophy, so we can give the disease modifying therapy, which include nusinersen and also onasemnogene. So this is detail. So and then we need to treat symptomatic. So if there is scoliosis, and then we need to put spinal bracing. And then if having problem with nutrition, then we need to maximize the nutrition. Okay, and if the baby or infant having the respiratory problem, we need to give respiratory support or ventilator. Okay. And also the important one is genetic counseling. Okay. So this is the picture of spinal muscular atrophy type 1, which called Wernicke-Hoffman disease. So showing proximal wasting. So they have this patient having the chest deformity from weakness of the intercostal muscle, as you can see at the up part of the intercostal side. Okay. 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 Move on to the myasthenia gravis. So myasthenia gravis is autoimmune disease. So which it associated with the acetylcholine receptor. So there will be autoantibodies block the acetylcholine receptor at the neuromuscular junctions, and this will decrease the number of effective receptor, and it will cause rapid fatigability of striated muscle. So it has 3 types. So which the first one is the juvenile myasthenia gravis, transient neonatal myasthenia, and also the last one is congenital myasthenia. So the clinical features of myasthenia gravis, we need to identify whether the infant or childhood having ptosis, diplopia, facial weakness, poor feeding, poor head control. So we can see obviously on the face of this child. So this child having ptosis. Okay. So for the types of the myasthenia gravis, so for juvenile myasthenia gravis, it present in late infancy or childhood, and so the child may complain of dysphagia, but in some children limited to ptosis and also ophthalmoplegia only. So for the transient neonatal and myasthenia gravis, so it will be present in the first hours to days after birth. So for congenital, there is not an autoimmune mediated. So it is basically due to gene mutation in the convergence of neuromuscular junctions. Okay, so for the diagnosis, we can do antibody testing and also nerve conduction studies and symptom improvement with cholinesterase inhibitor, which for example, androphonium. Particularly, it will improve the ptosis. Okay. So the last part is the congenital muscular dystrophy. So congenital muscular dystrophy is a group of genetically determined condition that presents in infancy or early childhood. So it is also autosomal recessive, but this disease is slow or non-progressive in most patients. So patient will have contractures, scoliosis, and also will have the diminished respiratory status with age, and also learning difficulty. So there are subtypes of the congenital muscular dystrophy. So but you just can see the features of the congenital muscular dystrophy. So infant or child will have hypotonia, extremity weakness, delay motor development, and also congenital contracture. So to diagnose congenital muscular dystrophy, so we can combine elevated creatine kinase and also dystrophic changes on muscle biopsy. Then we can diagnose congenital muscular dystrophy. Okay, for history, so the chief complaint, so mother will complain about the floppy since birth, slips from hands, less movement of limb, delay motor development, or the child may have frequent falls, difficulty in suckling or weak cry, which may suggest myasthenia gravis or SMA. So recurrent respiratory infections. Okay. So for the history of presenting illness, so we need to determine the onset, the cause, the severity, distributions, and also the excitations. And so if the onset is sudden, so we need to bear in mind to check for we need to suspect intraventricular hemorrhage. And for cause, if progressive, so we need to suspect spinal muscle atrophy, or if static, cerebral palsy. So, and other severity, so maybe the infant having apnea or respiratory difficulty, history of fatigue during suckling, history of constipation. So distributions, if proximal, if from proximal, so we can suspect it is myopathy. So for associations, so these are the association. If the infant having the muscle pain, joint deformities, we suggest arthrogryposis, seizures, abdominal movement like respond to visual, auditory stimuli, and also drowsiness. So for past medical and drug history, so we need to check for any history of meningoencephalitis, seizure, any past surgical history, head trauma, and also his or her current medications. So for birth history, so we can divide into prenatal, antenatal, and also postnatal. So prenatal, we can ask about is there an infection, tortuous infection, fetal presentation, polyhydramnios. Okay, for antenatal, we need to know the gestational age of the mother, gestational age of the infants, and also the abdominal presentation, and also mode of delivery of the infant. And also for postnatal, we need to check for the birth weight, length, and head circumference to if there is any failure to thrive or short stature. So, and also we need to ask about the birth trauma, birth asphyxia, delivery complications, and also neonatal hyperbilirubinemia, blood clot, which suggests hypothyroidism, okay, and others. Okay, for family history, so the age of parents is important. So it will suggest they will have arthrogryposis, and also history of consanguinity. So arthrogryposis or inborn error metabolism. And so family member can, if having myotonic dystrophy or okay. So for similar presentation, we need to ask about wheelchair dependent, spinal or skeletal deformity, functional limitation, early death or cardiac disease. So for development history, so we need to identify the infant having the isolated motor delay or global developmental delay. So if there is isolated motor delay, it will suggest that the infant having neuromuscular disease. If global developmental delay, so we can suspect any problem in synapse development. Okay. So for nutritional and growth history, so in myasthenia gravis, so the infants will have poor sucking over time or repetitions due to fatigue. So they will have also feeding difficulty, weight gain, or failure to thrive, especially in Prader-Willi syndrome, and also head circumference. Okay, for physical examination, so in general, we can check for the mental status, altered or not. So it's can point towards central causes, the quality of cry. So if the infant having weak cry, so it may suggest that the infant having respiratory muscle weakness, and also or congenital hypothyroidism. And also we need to inspect the posture of the infants, which suggests of hypotonia, and also any spontaneous movement. And also we need to see the dysmorphic features of the infant. And also we look at the head circumference, the scar, or any shunts at the head. And also the most obvious one is you can see obesity in Prader-Willi syndrome. Okay. So these are the pictures. So the small girl, girl. So there's a ptosis, so it suggests a myasthenia gravis. So this one is a face features of Prader-Willi syndrome, and also this is the Down syndrome features. And the posture is due to hypotonia. Okay, so arthrogryposis means there is this group of non-progressive conditions characterized by multiple joint contractures found throughout the body at birth. So the joint contracture, a non-specific consequence of intrauterine immobilizations. So it varies in severity from clubfoot, the most common manifestation, to symmetrical flexion deformity of all limb joints. So first clubfoot, and then it will progressive and will cause the flexion deformity of all limb joints. So okay, this is the pictures. Okay, so this one is the severe one, the severe ones of the arthrogryposis. Okay, for neurological examination, we need to check from head to toe, so head and neck. So we need to check for cranial nerve. So because of having ptosis or facial asymmetry, tongue fasciculation, which suggests spinal muscular atrophy, and also limb examination. So we can do inspection to check for any scar, wasting, and then fasciculation, and also we look for tremor, tone power reflex, which suggest hypotonia, hyporeflexia, areflexia. Okay. And also we need to do hypotonia evaluation. So these are the we already learned this, how to differentiate between upper motor neuron lesions and also lower motor neuron lesions. So for the lower motor neuron lesions, they have hyporeflexia and hypotonia, and also their presence of fasciculation. However, the Babinski is negative. Okay, so for the post-hypotonia evaluation, we need to see the postural tone of the infant. So the posture, so first we can see the infant having frog-like posture, like in this first picture. So, and then we also can see a vertical suspension. So if hypotonia, so when you lift up the child or infant, so they will be hanging and scissoring of the lower limb. And then for horizontal suspensions, there will be inverted U shape of the infant. And also the last one, there will be extreme head lag, like this one. So, okay. Okay, this one you can see the extreme head lag, the inverted U shape, which suggests hypotonia. Okay, for other examination, you can do developmental assessments, cardiovascular examinations. We observe any signs of cardiac failure, such as muscle or mitochondrial disease, especially in Pompe disease. The infant will develop cardiac failure and also can have cardiomegaly. So for abdominal examination, we also can see any hepatosplenomegaly, suggests a lysosomal or glycogen storage disease. Okay. So for investigation, so it depends. Okay, it depends. Either is it upper motor neuron lesions or lower motor neuron disorder. So if we suspect there. Okay, yeah. Okay, for infant with central hypotonia, initial investigation include karyotype and also neuroimaging, which is CT or MRI brain. So if, especially when the child is having dysmorphic features of face, we need to do karyotype. So for example, in Down syndrome, trisomy 21, and then for Prader-Willi syndrome, so we can do FISH. So for Zellweger syndrome, so we can do VLCFA. Okay, for CT MRI brain suggests hypoxic ischemic encephalopathy, cerebral malformations. So for lower motor neuron disorder or peripheral, that can from peripheral cause, so we can do creatine kinase assay, EMG, nerve conduction studies. So this I already explained at the previous slide. Okay. Okay, so for the management, so the the important one is we need to treat the underlying disease. So mostly in genetic problem or syndromes, we need to give a supportive treatment. So we need to give supportive nutrition, we need to do physiotherapy if the infant having a contracture to prevent any contractures, occupational therapy to improve on posture and functions, and also to facilitate activities of daily living. So if the patient having problem with scoliosis and also hip subluxations or dislocation, we can refer to orthopedic team. And also we can give vaccination also as a prophylaxis against respiratory infection due to immunocompromised state. And also feeding intervention, especially those infants having problems with sucking. Okay, so we need to give food through nasogastric tube, and also need to maintain the idle weight. Okay, that's all. Doctor?
Yes.
I already finished.
Thank you, Shazwani. Good.
Okay.
I think you got heavy dinner, not heavy lunch. Just I would like to, if we come back to the pictures of hypotonia, that baby you are carrying him, come again, postural tone. It's the one before. Yes. Usually we are doing one test. Just remember, it will be easy for you, known as 180 test, 180-degree test. So like this picture to the right, I will try to pull the baby from both hands and see the head leg. Okay. Please catch both hands by one hand and support the head, because sometimes if he's very hypotonic, it may be a bit dangerous for him. So you must put your hand below his head. Okay. So this is step number one. Okay. Number two, you are going to go for number three. Catch him from the both axilla. What will happen? He will sleep because he's hypotonic. He cannot be strong to be catched by your hands. He will slip from your hand. The one which you speak about before, which is sleeping from hands. Okay. Then if you put him on the middle one to see his back, you will find his back like the one after that. It is arched. He cannot make his back also stretched because of strong muscle. You will find his back is arched. So number one, there is head lag. Number two is slipped from your hand. Number three, when you put him on your hands, you will find him, as you see, the back is arched. And even if you put him on face, he is not unable to move. He's one from side to side like that. And at the end, frog leg position is one of the characteristics. But remember this 180-degree tests. Okay, this is number one. Just to comment. You speak about Shazwani about a good thing, which if the baby delivered looks strong and like that, and within 1 day he started to be hypotonic, so you are thinking about inborn errors of metabolism. Okay, why? Because he started. Yes. Can you answer?
Because there will be the toxic accumulation in muscles.
From where this toxic accumulation?
From the from the carbohydrates, protein, and so on.
So it is from feeding.
From
most
feeding.
of them, until we start feeding, they will start to appear. That's why if you suspect any inborn errors of metabolism, it is better to make him NBO and give plain fluids until you come to diagnosis or collect your samples. Okay, so this is also an important point, and the most important is to divide his floppy and weak and floppy or strong is very important. Okay. I think all of you did a very nice job, but I don't know, you are not put in your mind how to write reference. I hope one of you can just make it a simple one page how to write reference. So it will be once. If you taught it, it will be finished. Okay? Who can do that because it is lagging? Okay? So I need to assign one from your group, please, to write how to write a medical reference in the medical career, please. It is very important. Now it's your time. We have 5 minutes now. If you need to ask any question, please.
Assalamualaikum, Prof.
Yes.
I would like to ask regarding the acute transverse myelitis. Is it the deficit is ascending or descending? Like in GBS is
yeah, it is not like GBS. It depends which part of the body is affected. So it is from lower. It will start from the leg, morely affected. If it progresses to the upper limb, sometimes it looks like, but sometimes it is not affecting all. Usually can be only lower limb and stop like that. But if progress to affect also the upper limb, it looks like Guillain-Barré, but it is not the same because the other symptoms is not typical. Okay, but Guillain-Barré is a standard ascending one. You cannot say for the other it is ascending. Okay.
Thank you, Prof.
Welcome. Any other question? So today we are trying to touch many things. Is it the baby is floppy, or he is flaccid paralysis, or he has hypotonia? Theoretically, there is a lot of detail for everyone, but your first job is to know. While you are coming now from the tools, he will tell you, if you go right, you will go to Trigano. If you go left, you go to KL. If you go another way, you can go to another area. Yes, it is the same. Please don't confuse yourself. Try to start by clear cut what is your case. And I think you spend with us about 5 years now, or 5 years, or 4 years and 9 months, still remaining for you 3 months. And then you will be transferred from theory and minimal practice, or I think maybe observational practice, to actual paralysis. From theory to practice. So please prepare yourself. Remember that every case, I used it to tell that even the simplest one, even we are speaking about tonsillitis, which you used to see it many times per day, can have a lot of details. Okay? How is the degree of enlargement of the tonsil? Is it viral or bacterial? How can it differentiate between bacterial or viral? Is it sole, or it is a part of systemic disease? Okay, because sometimes it can be a part of systemic disease like infectious mononucleosis, which can cause a lot of problems. But this tonsil has any complication or not? It may be the patient has rheumatic fever or like that. So it may be, the title is very simple, but there is a lot of very important details in the benefit of the patient. And remember that this patient can be one of our relatives, can be one of lovely person to us, can be any humankind. You must كما قال الله رحمة للعالمين. We must be able to give help and empathy to all the world. So even the simple diagnosis, it can carry with you a lot of details. This is your rule now. You retained a lot of knowledge, and I see, mashallah, you can speak forever about a lot of details, but the next time, how can you present it to the exam? I mean by the exam, examining the patient, not the final pro. Examining the patient is your challenge. Patient come to you and he has convulsion and status epilepticus, and you need, number one, to stabilize him. Number two, you need to know what is the cause. So a lot of details. If he came to you floppy, there is another pathway. If he go to you acute flaccid paralysis, you have a lot of headache and a lot of ideas and a lot of investigation. That's why, please, try to be deep. Don't be superficial. Medicine doesn't accept to be superficial. Okay? You must be very professional to give benefit to yourself and to your patient and even to your community and your ummah. It is very important. If we still slow, the one who is hurry can be in advance to us, and that is the thing which happened. Now, hopefully, you are starting now to do researches. You are starting to think to apply everything. This is the actual thing which you can give to your country, please. Okay. Thank you for a nice presentation. And I hope, inshallah, I can hear the best about you in the coming few months, and see you, inshallah, with us soon.
Amin.
Thank you for your presentation. Ayman, Azhar, and Shazwani, thank you. And thanks for your attendance, inshallah. Azhar, I think you need to send us the modified lecture, because the lecture send is old one.
Yeah, the initial one I edit.
Yes, and if you are able to put your reference by scientific one and drop it to me and Farah, it would be better.
Okay.
Okay. Thank you. Assalamu alaikum.
Thank
you, Rada.
Thank you, Prof.
Thank you, Prof.
Welcome.
Thank you, Prof.
Assalamu alaikum. Thank you.